Good morning. My name is Lori Barton, and today we're going to discuss peripartum complications in this podcast. Included in this lecture is going to be embolic complications, retained placenta, as well as maternal CPR. So let's go ahead and get started. Embolic disorders, including the three that we're going to discuss today, represent the most common cause of maternal mortality in the Western world. It's important that we think about these and pay attention to these when we're dealing with our pregnant population. Pulmonary thromboembolism, for example, occurs in 0.01 to 0.05% of all pregnancies, and of note, most common cause is DVT. We're also going to be discussing venous air embolism as well as amniotic fluid embolism today. So like we said, in pulmonary thromboembolism, DVT is the most common, but be aware that superficial vein thrombosis occurring in the antepartum period happens as often as 0.5% of all pregnancies. Half of the case of thromboembolism in women of childbearing age occur during pregnancy or the peripartum period. That's incredible if you think about this. As we said, during pregnancy, DVT is the most common, and it occurs most often in the antepartum period. However, of those cases that go on to develop pulmonary thromboembolism, 2/3 of these are in the postpartum period. It's important to note, though, recently that the incidence of DVT has decreased due to increased efforts to get patients up and ambulating postpartum. So why is pregnancy such an issue when you think of pulmonary thromboembolism? Basically, it's because of these three reasons here: venous stasis, hypercoagulable state of pregnancy, as well as vascular injury. So when you think of venous stasis, you have to think about the enormous increase in the size of the uterus. At term, the uterus blood flow increases to about 700 to 900 mLs per minute, which is about 10 to 12% of the maternal cardiac output. So you've got this large gravid uterus that compresses the inferior vena cava, and as a result, you get an increase in venous stasis. During pregnancy, you also see a change in coagulation. You get enhanced platelet turnover, you get enhanced coagulation, as well as enhanced fibrinolysis. You see an increase in coagulation factors, but you also see an increase in thrombin generation. Important to note is that during the first 48 hours of delivery, you get the decreased activity of fibrinolytic activity, but that coagulation activity does not also see that same decrease. Therefore, you get a very large imbalance, contributing to an increased risk of pulmonary thromboembolism. And then finally, there's vascular damage. In vaginal deliveries with separation of the placenta, there's vascular trauma, which leads to an acceleration of coagulation activity. Cesarean delivery can further cause vascular trauma and continues to increase the risk for embolism. Of note, the risk of both DVT and pulmonary thromboembolism are 8 times higher after cesarean delivery than after vaginal delivery. And then finally, you want to think about your high-risk pregnant population. Thromboembolism is increased in patients who have preeclampsia as well as multiple gestation. So when you think about the diagnosis of pulmonary thromboembolism, you have to look at your patient clinically, physical exam, as well as what kind of tests are available to you. So clinically, you're going to see a patient who is dyspneic, they have palpitations, anxiety, chest pain, which might be pleuritic in nature. The patient might also be more extreme, cyanotic, diaphoretic. In your physical exam, you have to think about signs of right heart failure. You would listen for a split second heart sound, jugular venous distension, hepatic enlargement. In a patient, you'll look for tachypnea, you'll listen for crackles or decreased breath sounds. In the lower extremity exam, you'll look for signs of DVT, calf or thigh edema, erythema, tenderness, or a palpable cord. And then on EKG, you want to think about right ventricular strain, right axis shift, P pulmonale, ST, T segment abnormalities, and T wave inversion. So testing for pulmonary thromboembolism is very much a balance between exposing the mother and fetus to minimal radiation, as well as trying to get a timely diagnosis. Of course, you can always think about a D-dimer, which is a very non-invasive test. A negative result, a probability of pulmonary thromboembolism is less than 2% in a non-pregnant patient, and no further testing is required. However, pregnancy complicates things because A positive test is not specific for PTE in a pregnant woman. D dimers are detectable during the second trimester, and they continue to rise during normal pregnancies, and they return back to baseline 6 weeks postpartum. So D dimer is not an ideal test during pregnancy. You can look at a lower extremity venous ultrasound. This offers the benefit of no radiation exposure. However, false negative rates may be as high as 10%. A chest x-ray gives you little value. It might show some atelectasis, some pleural effusion, an elevated hemidiaphragm, segmental infiltrates, but it's neither sensitive nor specific for pulmonary thromboembolism. You can look at a VQ scan, and they're common, they're efficient, they're safe in pregnant patients. If it's normal, a PTE can be excluded. However, if there is a high clinical suspicion of pulmonary thromboembolism and the VQ scan indicates a high probability, then no more tests are really needed, and the diagnosis of PTE is made and anticoagulation therapy is begun. And then finally, the gold standard, of course, is your spiral CT. This is done in the pregnant population if there is a high clinical suspicion and the VQ scan is indeterminate. It's extremely sensitive and specific. In both the VQ scan and the spiral CT, they can be modified by radiologists to decrease the amount of radiation exposure. Although judicious use of radiation exposure during pregnancy is wise, most radiologists feel that small amounts of radiation exposure more likely increase fetal risk to a very, very limited extent. So once you have a diagnosis, you have to start thinking about treating a patient. Unfractionated heparin should be immediately started after the diagnosis of a DVT. Recall heparin works by bonding to antithrombin 3. When bound, antithrombin 3 accelerates its action on deactivating thrombin, factor 10A and factor 9A. Heparin dose requirements are about 50% higher in the second and third trimester, and they might be higher in pregnancy due to the increased amount of coagulation factors. The level of anticoagulation is evaluated with a PTT, which should be kept at 1.5 to 2 times the normal range. So IV therapy is continued for 5 to 7 days with a transition to subcutaneous heparin. Heparin therapy is discontinued when active labor begins, and ideally for at least 24 hours prior to a cesarean section. Postpartum, the patient can restart heparin therapy after the patient is stable and hemostasis is affirmed. Warfarin is started concurrently and is monitored with a goal INR of 2 to 3. Once this is achieved, heparin is then DC'd, and warfarin can be used during breastfeeding. Anticoagulation is then considered for at least 6 weeks postpartum. Low molecular weight heparin is used for both prophylactic and therapeutic anticoagulation during pregnancies. Low molecular weight heparin affects antithrombotic activity rather than anticoagulant activity. Therefore, its effect is not measured by a PTT. Benefits of low molecular weight heparin are increased decreased risk of HIT. There's going to be less bleeding disorders. Decreased risk of osteoporosis with low molecular weight heparin as compared to heparin. And then obviously for a massive PE, you want to consider thrombolytic therapy such as urokinase or streptokinase. You always have to consider what type of anticoagulation a patient is on whenever you're considering a neuraxial anesthetic. Insertion of an epidural needle causes some bleeding in the epidural space in about 10% of healthy patients. Now, this is not included in the in your pregnant population, so that number is presumably going to be higher. The risk of hematoma seems to be increased by traumatic or repeated spinal or epidural punctures. It appears obvious. So you always want to refer back to your ASRA guidelines. So if a patient is on systemic IV heparin, there's really no recommendation before placing an epidural if a patient is already on this IV heparin. You want to wait at least 4 hours after the last dose of heparin, and you absolutely want to reassess the coagulation labs prior to removing the catheter or starting catheter insertion. It would be prudent before placing the epidural to make sure that the BTT is normal or near normal, although there's not really a specific range that ASRA recommends. Patients and obstetricians should be counseled that prophylactic use of low molecular weight heparin precludes the use of neuraxial anesthesia at least 12 hours since the last dose. Now note that is for the prophylactic dose of low molecular weight heparin. The use of therapeutic low molecular weight heparin precludes the use of neuraxial anesthesia for at least 24 hours. So let's move on to venous air embolism. Venous air embolism is a common occurrence regardless of the method of delivery, both vaginal and cesarean it is common, and regardless of the type of anesthetic, either general or neuraxial anesthesia. Studies with patients having cesarean section have a wide range of incidence from 67% to 97%. Obviously, most of these are not going to be clinically significant. It's important to note that left uterine displacement and the use of Trendelenburg increases the risk of venous air embolism. It is important to note also that a pressure gradient as small as -5 centimeters of water between the surgical field and the heart allows for enough amount of air to be entrained into the venous circulation that it might become an issue. Precordial Dopplers can detect volumes of air as small as 0.1 mils. The morbidity or mortality from venous air embolism are related to the volume and the rate of infusion of air into the central circulation, as well as the site of the embolization. Large volumes, meaning greater than 3 mils per kg of air, are fatal, and this is probably due to the mechanical effect of an airlock. Smaller amounts can result in VQ mismatch, hypoxemia, right heart failure, arrhythmias, and hypotension. Paradoxical embolism can also lead to cardiovascular and neurologic injury. So what is going to be your presentation? It can manifest as a sudden dramatic event with hypotension, hypoxemia, and cardiac arrest, but more commonly it's far less dramatic, and the patients will complain of chest pain, decreased oxygen saturation, and dyspnea. You'll want to look at EKG changes, including ST depression, but be aware that ST depression is seen in about 25 to 50% of all patients undergoing cesarean section. So patients who have suffered from massive venous air embolism, you want to obviously prevent further air entrapment. You want to stop using your nitrous and give 100% oxygen. You want to support ventilation, support circulation. You want to consider a multi-orifice central catheter to attempt air aspiration. You want to expedite delivery. And then if a patient is experiencing delayed emergence, you want to consider neurodiagnostic imaging. In patients that have had a major insult from venous air embolism, you always have to consider hyperbaric oxygen therapy. So let's move on now to amniotic fluid embolism. The incidence is anywhere between 4 and 6 per 100,000 live births in the United States. Mortality is varied between 25 and 80%. It's important to note that the presence of meconium in the amniotic fluid was associated with a uniformly dismal prognosis, with no survivors having escaped neurologic insult. In one study of the survivors that they looked at in the U.S., only 25% of the 12 cases that were looked at were deemed neurologically intact. And those are patients that did not have the presence of meconium in the amniotic fluid. Amniotic fluid embolism can occur almost any time during the pregnancy. It can occur as early as the first trimester during abortion, during the second trimester, and then also after abdominal trauma and in the postpartum period. Of note, 2/3 of AFEs occur within the first 5 hours of delivery. At this point, amniotic fluid embolism is a diagnosis of exclusion, and it always has to be on your differential in an unstable patient. So typically we speak of the biphasic response when we describe amniotic fluid embolism. Phase 1 is transient pulmonary vasospasm. Now this is due to the mechanical effect of amniotic fluid causing a release of vasoactive substances. It's due to the chemical effect due to the release of vasoactive substances. There's not really a mechanical obstruction of flow into the lungs, which some people think of when they think of amniotic fluid embolism. So patients are going to see initially right heart failure, which is oftentimes fatal, low cardiac output leading to VQ mismatch, hypoxemia, and hypotension. This first phase generally lasts less than 30 minutes. If a patient is fortunate enough to survive this first 30-minute phase, they move into the second phase, which shows left ventricular failure and pulmonary edema in women who are able to survive that initial insult. Differentials, prior to an amniotic fluid embolism diagnosis, the clinical presentation has to be assessed, and this is going to include hypotension, fetal compromise, pulmonary edema, cardiopulmonary arrest, cyanosis, coagulopathy, dyspnea, seizure, atony, bronchospasm, transient hypertension, cough, headache, chest pain. So it's a pretty wide list of complaints that they might have. But when you think about the differential, obstetric complications include placental abruption or eclampsia. Non-obstructive complications include any of the embolisms we've previously talked about, septic shock, MI, anaphylaxis, and then you have to think about what we as anesthetics or as anesthesiologists have done and what type of anesthetic complications they could be experiencing, like total spinal or LAS toxicity. So management of amniotic fluid embolism is mostly supportive, initiating CPR, IV resuscitation, so you want to make sure you get large bore IV catheters, A-lines, central lines with a PA catheter, inotrops if needed. Consider getting a transesophageal echo. You want to make sure that you're doing fetal monitoring, and you also want to make sure that you've got great communication with your obstetricians and thinking about delivery. Intact maternal survival after cardiac arrest is extremely rare. The one chance that the mother has of surviving oftentimes is delivery of the fetus. And so thinking about the delivery might be of benefit to the mother undergoing CPR. So in patients with amniotic fluid embolism, it's recommended that a C-section be started immediately after maternal cardiac arrest. You want to also think about treating coagulopathy. These patients will often deteriorate and develop DIC. And then obviously you want to manage the sequelae of shock. So moving on, we're going to spend a little bit of time talking about retained placenta. The management of a retained placenta really kind of depends on the presence or absence of hemorrhage. It's important to understand that retained placental fragments are a leading cause of both early and late postpartum hemorrhage. When the interval between delivery and placental delivery is longer than 30 minutes, the risk of postpartum hemorrhage increases. And whether or not a patient is hemorrhaging is really going to dictate how you manage a patient with retained placenta. Most of the time, your patients might have an existing epidural catheter to give them adequate analgesia as the obstetricians try to retrieve the retained placenta. You could also consider in a patient that does not have a working epidural a spinal anesthetic. Other options are going to be nitrous oxide, ketamine, as well as fentanyl. However, if hemorrhage is significant, the benefits of Neuraxial need to be weighed against the sympathectomy in the face of unstable hemodynamics. In this situation, general anesthesia needs to be considered. So during retrieval of retained placenta, the obstetricians are going to have greater success if you're able to achieve uterine relaxation. If general anesthesia is given, you can use your inhalational agents to allow for adequate uterine relaxation. By achieving 1.5 MAC with either sevoflurane or desflurane, you can get a decrease about 50% in contractility of the uterus. A better option for uterine relaxation in a patient that is not undergoing general anesthetic might be nitroglycerin. It has a short half-life of 1 to 3 minutes, and it also has a rapid and predictable onset. So finally, let's talk a little bit about maternal CPR. ACLS is applicable in parturients. Few additional considerations have to be thought about. In these patients, you want to intubate earlier in the resuscitation process to protect from aspiration and facilitate oxygenation. Chest compressions should be slightly higher above the sternum to account for the elevated diaphragm, and then you want to maintain left uterine displacement with a bump under the mother's right hip. Of note, ACLS Guidelines also advocates the use of somebody to manually pull the gravid abdomen and uterus off of the inferior vena cava to increase the cardiac preload that's going to be returned to the heart. If initial efforts to restore oxygenation, ventilation, and circulation are unsuccessful, then you absolutely have to consider C-section in a patient who is greater than 20 weeks pregnant. Initiation of C-section within 4 minutes and delivery of the fetus by 5 minutes is the goal. As we discussed earlier, delivery allows for relief of the aortal cable compression and restoration of venous return to the heart. If delivery does not facilitate successful maternal resuscitation, you absolutely have to consider cardiopulmonary bypass in worst case scenarios. Thank you for your time, and I look forward to our discussion on Thursday morning in our flipped classroom.